Good morning, everybody. It's lovely to be here in this beautiful city of Salalah, Oman. My name is Yasmin Sujad. I'm the consultant of obstetric gynecology and a subspecialist in reproductive medicine and neurology and IVF. And currently I'm the technical director and academic director of Turkey IVF Center in Abu Dhabi. And I would really like to thank the organization to invite me, and also Merck for inviting me, and the general generosity and the welcome you guys have given. Thank you very much. Can I have the first slide, please? Thank you. Sorry, is this the marker? Yes. I was halfway, I came. Oh, I can control it from here? Yes. Yes, okay, that's fine. Thank you very much. So I was listening to very elaborate talk on infertility, and it was superb. But I'm going to go on to, as the speaker said towards the end, individualizing the treatment of ovulation induction and IVF, and that's very, very important, okay? Because unfortunately, one size doesn't fit all. As everybody says that you give this treatment, that treatment, and it will work. For me, I take patient as an individual person. And I always say that you go to a supermarket or your mall, you go to Zara, okay? I might fit into a size 16 with Zara, I might fit into size 18 in another shop, and till I try a couple. But if I go to a tailor and I ask them to give me, measure me and make a dress for me or a suit for me, they will make a perfect dress for me, because they will measure me, and if it's not correct, I'll go back and they will adjust it. So I'll have a proper tailor-made suit from a tailor. So consider us as tailors, okay? To give a better outcome to the patients in terms of live birth, and also in terms of safety and good quality of care. It's not about one size fits all. It has to be tailor-made to the patient, because as doctors, it's our duty to do best for our patients. Yeah, and my talk will prove that, and I'm happy to take any questions after that or in between if you want to ask. So, as I said, individualization is very important, because IVF or assisted conception or ovulation induction or any treatment that involves monitoring and assessing the patients and give the best. So in my field, IVF, I call it, it's a roller coaster ride, right? It's very, very stressful for the patient, as the previous speaker said counseling is very, very important. And in my field, I think 60–70% is all counseling. The rest comes with treatment. So you have to see the patient first. You have to get the proper history. You have to get the diagnosis. First, get your facts right before you move on to the next stage. Then you do the investigations, and based on that, you do the strategy, the treatment plan, and then you execute that treatment plan properly, effectively, and safely, right? And then in the end is the outcome, the live birth. So if you see, all this comes in safety, quality, and patient-centeredness. So you involve the patient in that, and you involve the patient at every step. I don't tell my patients, this is right for me, and you have to listen to that. I give them options. I give them 2, 3, 4 options with its pros and cons, with its complications, and then let the patient decide, and we mutually decide. I would not let the patient make a dangerous decision of transferring 2 embryos or 3 embryos to them to increase the risk of multiple pregnancies. And if you logically explain to the patient, they will understand. Similarly, by different treatments, with endotropins, injections, and all that, I give them an option. They might not understand, but if you put them in easy lingo, in easy explanation, they will understand. Okay, so that's all about sort of involving the patients in making the choice. And this will increase the outcome and also will reduce the side effects. In my field, as the previous speaker said, the risk of OHSS is extreme. If I give OHSS to a patient, or if I give triplets or quadruplets to a patient, I will think that's failure in my part. I want to give the best to the patients, to take a healthy baby home without any complications and side effects. So that's really important right from the beginning, that we get the facts right, we individualize the treatment, and we reduce these risks of multiple pregnancies and also ovarian hyperstimulation, which we'll see later on. And I'll also prove it with studies to see how you can individualize and you can give proper treatment and with less risk to the patients. So, as I already said, safety, effectiveness, and patient-centeredness is very, very important, and that's all about our treatment as a doctor, giving treatment as a doctor. So, whenever we think about individualizing the stimulation protocol, we take into consideration the clinical characteristics. As I said in the beginning, that when we see the patient, you take a proper history. By taking a proper history, you get diagnosis in almost 80% of cases. The patient, the first 5 minutes, I get my diagnosis. I know what the patient has got and what treatment I'm going to give, right? The rest 20% comes with examination and investigations and biochemical picture and all that. And this, by taking the history, then you're doing the clinical investigations, that is, you do the biomarkers by doing the hormonal analysis, the ultrasound, that gives you another 15-20% of your answers. And this completes the picture that you know the patient sitting right in front of you is in which category, right? And the three categories that we want to identify in our treatment is either they are the normal responders, they might not give any trouble, they might be okay. They are high responders, that means they're at the verge of going into PCOS, and as the previous speaker said, the WHO group 2, or they are low responders. That means these patients have extremely low ovarian reserve or premature ovarian follicle and all that. So once you identify these three groups, then you plan your treatment accordingly, okay? And this sort of will give you an idea what you need to do next, okay? So the different biomarkers that we use in my field one is the AMH, the anti-Mullerian hormone, antral follicle count, which is done on day 1 or 2 or 3 of your periods, that is done by transvaginal route, and FSH is a third, okay? And of course, the age also counts. For me, these 3-4 biomarkers is more than enough to make a protocol. On top of that, I look at the previous cycles as well. If the patients had multiple IVF cycles or multiple treatment, and we need to know what sort of treatment they had and what sort of response they had, then you tailor-make that, right? So you adjust, you started adjusting the dress the tailor is making, okay? Now, if sort of there has been studies which shows that if the AMH is more than 3.4 nanogram per mil and the antral follicle count is more than 15-16, those are the patients at high risk of ovarian hyperstimulation. So in those cases, you have to be very careful when you are giving any sort of treatment, whether it's ovulation induction or whether it's IVF. But if somebody has got less AFC, antral follicle count, and less AMH, and previously poor response of not getting any eggs or not getting any success, then they fall into the category of poor response. In the Middle East, almost 67 to 70% of the patients have got PCOS. Every day in my clinic, when I see 20-25 patients, out of those, more than half are PCOS in different shapes and forms. They could be obese PCOS, they could be lean PCOS, they could have sort of the increased AMH, or they have increased central follicle. And then, you individualize your treatment according to that. The main worry for me are the lean PCOS patients who are at increased risk of ovarian hyperstimulation. So that's sort of how we identify and then plan their treatment. Now, increasing the risk of ovarian hyperstimulation. So that's how I do the low step-up protocol. We start with 37 or 50, or even if you're worried, then go on alternate day. And to tell you, I mostly take the antral follicle count. So I scan the patients if she has got multiple follicles, and even if her AMH is within the normal range, I go by the AFC. And then slowly and gradually monitor. And once a dominant follicle reaches, it could be 10 days, it could be 15 days, it could be 17 days, it could be 20 days, but you monitor it with their estradiol and the LH level as well. And you can see all of a sudden, sometimes from day 10, day 11, day 12, you see this LH is creeping up and the estradiol is going up, and the follicle is developing, right? I know the patient will be anxious and will be wanting you to do something, but just to say, slowly and gradually, slow and steady, win the race, yeah? And then once the dominant follicle is reached, then you can give them trigger, whether you give the 250 or 500 microgram, and then followed by luteal support, okay? Now, there were studies shown, what about there are physicians who are giving combination of Clomid and gonadotropins. I personally don't. I only use one. Maybe I'm very cautious, but that's how, and I go by evidence-based medicine. So the studies have shown that if you give combination of Clomid and gonadotropins, yes, it will lead to ovulation, but there's increased risk of cancellation. And why cancellation? Because either they have multiple follicles develop, or they have sort of the risk of ovarian hyperstimulation. And if somebody has got 4 or 5 follicles, you're going to cancel the cycle. And I gave you earlier on my example of a patient, right? So ovulation occurs in 57% of cases, but cancellation is very high. But if you just use mono treatment, either Clomid or gonadotropins, a single, that ovulation will occur in almost 90% of cases, and the cancellation level is low, and reducing the risk of ovarian hyperstimulation and multiple pregnancy. So let's sort of go to the IVF treatment. Now, IVF is in normal ovulation inductions, you give a small dose of gonadotropins and hope for a unifollicle formation. In IVF treatment, we want a number of follicles because we are doing a controlled stimulation, and we will be collecting the eggs and creating embryos, and we can use one at a time to help them get pregnant with safety. So they receive a stimulation, whether it's an agonist protocol or antagonist protocol, and I'll talk about it a bit later. You start the stimulation and you do baseline scan and start with 100, 112 or 225, depending on which category the patient is falling. If it's a high response patients, I sometimes start even with 100 or 112.5. or 150, depending on the antral follicle count and the AMH level and her previous response. And then we bring them on day 5. We monitor again the blood levels, the estradiol rise, and we look at the scan for the number of follicles and the measurements. If she has got follicles between 12, 13, 14 millimeter on day 5, the estradiol level rise is in proportion with the ultrasound picture. We carry on the same dose. And then we start an antagonist, because when the follicle starts getting bigger, when they reach 16, 17 millimeter, they can rupture. We don't want them to rupture, so we just put a lid on it by giving an antagonist, so that the follicle starts growing, the egg keeps on maturing, but the follicle does not rupture. And we want them to rupture at a time which is convenient for us. So we bring them back on day 9 or 10, we scan them again, And once the follicles, at least 2-3 follicles are 16-17 millimeter, then we give them trigger and we do the egg collections 35 to 37 hours later. Irrespective of whatever follicles are there, we will take them for collection, right? And we collect all the eggs. We fertilize the eggs with the husband's sperm on the same day. And then depending what is the clinical status of the patient, what was her estradiol level at the time of the trigger, and what was the previous, and the serum progesterone level, we decide whether this patient is going for fresh embryo transfer or we're going to freeze the embryos. If the patient is going for genetic screening, then we may have to freeze the embryos depending on when we get the results, or if the serum progesterone level is high, then we have to freeze the embryos, or if there's any endometrial polyp or anything in the endometrium or endometrial fluid, then you have to freeze the embryos. And then the embryo is monitored for 5 to 6 days, and day 5, day 6, we do the embryo biopsy, and then if it's a fresh transfer, we will do transfer, otherwise we freeze the embryos. Now, the monitoring is very important because if the patient level, estradiol level is very high and she has increased risk of ovarian hyperstimulation, I will freeze the embryos. I will not go with a fresh transfer. Even if the patient is clinically well, because if I transfer embryo and the patient even is clinically well and she gets pregnant, then estradiol produced from her pregnancy and all the hormones is like fuel for the fire. The ovaries are already, were big, and that will not let the ovaries shrink. And if the patient gets pregnant, that will increase the risk of ovarian hyperstimulation and even death. I have seen a patient who was Jehovah's Witness in UK, and she got pregnant like this. She was PCOS, she had a fresh transfer, she got pregnant, and then she was really, really in bad state. She was asked to terminate the pregnancy to save her life. She chose not to terminate the pregnancy, and we had all sorts of, people and court involved for her to termination. She refused. She decided to die, but rather than to terminate because of her religious beliefs and all that. So we do not want to reach to that stage. We do not want to sort of put ourselves and the patient in that state. So that's really, really important that you take the patient's safety very, very seriously. Okay? And then they have a pregnant, once the embryos are transferred, or if they are frozen, then they are transferred the next cycle in a frozen embryo replacement cycle, which is much, much safer. And the outcome and the pregnancy rate in frozen embryo transfer is much, much better compared to fresh. So here comes the counseling. Here comes explanation to the patient right from the beginning that this is what I'm going to be doing. This is what, all this I discussed with the patient in my first and second consultation. So the patient is fully informed what to expect later on, rather than you dropping a bombshell on her, later on or in the treatment. Okay. Regarding the gonadotrophins, it's been sort of, it started like in 1920 when the HCG was identified in 1927, and the actual, the gonadotrophins were once the first IVF was done, and Louise Brown was born in 1978. That's where the gonadotrophins were used. Previously, these gonadotrophins were used from Chinese hamsters' ovaries, and then later on the HMGs from postmenopausal women urine, and later on the recombinant FSH were introduced. So I think I already touched on that how you identify the low responders, the normal responders, and the high responders patients, and then you plan their treatment. So if it's a high responder patient, I always said that we use an antagonist protocol. And I don't know how many of you are aware between different types of protocol. There are two types of protocol mainly, which is one is the agonist protocol, and the other is an antagonist protocol. Antagonist protocol is that on day 1 or 2 of the cycle, the patient comes, you scan them. If the bloods are fine, then you start them with the gonadotrophins. and then you monitor them for up to day 5, and then you add an antagonist, which I said to you, we put a lid on the follicles and then carry on. This is important for the high responders patients, because later on, when the follicles are ready, you will be giving them HCG for trigger. If in these patients, the high responders, you give them HCG, you are actually putting the kerosene oil on the fire to get blow, increase more risk of ovarian hyperstimulation. So instead of this, we give them the GnRH analog. It's an agonist. We are basically pushing their own pituitary to produce that LH. And the risk of ovarian hyperstimulation is much, much reduced in these patients with the GnRH agonist. Okay. In the normal responders, you can use antagonist or you can agonist. There's no studies have shown not much difference, and you can comfortably give them a trigger, HCG trigger in them. The low responders, again, you can use antagonist or agonist. There's not much the problem in there. The agonist protocol that we usually use in patients who have got endometriosis. And the way we work on day 21 of their cycle, we downregulate them. We give them GnRH analog and we suppress their ovarian function. We take control of their ovary. And day 1 or 2, when they start bleeding, then we start using the gonadotrophins. But we continue with the agonist and keep this lid on till they are ready for trigger. And at the end, when the follicle is developed, then you can give them the HCG trigger for at maturity. Why we use agonist in endometriosis? Because in endometriosis, there is the endometrioma. It affects the quality of the eggs, and also it affects the endometrium as well. So by giving that suppression, we suppress endometriosis. You can start it from day 21, or if they're severe grade 3, grade 4 endometriosis, I usually sometimes give them for 3 months before. So I completely stop their periods and then start stimulating them. So that increases the chances of pregnancy. And as my previous speaker said, that the endometrioma, in some certain cases, it needs to be removed. In some cases, you can leave it. Again, studies have shown that if endometrioma is around 5 centimeters or so, and it's not affecting my technical collection, then there is no sort of evidence that by reducing that, you are improving the pregnancy outcome. And that has been shown in the SRM and ASHRA studies and the recent guidelines as well. So I already touched on that. In the normal responders, the main goal is to get effective treatment, and the number of oocytes and the protocol could be under 35. You can use, antagonist plus recombinant, and in over 35, you can use a combination of recombinant and recombinant LH. The poor responders, again, it's important in these patients that you give, it's a patient-centeredness, because these patients have come from different centers. Patients come to me after having, 10, 15, 18 IVF cycles, and they completely fail. So then you have to make a plan and properly get the right treatment protocol for them. And these patients are extremely, extremely stressed, right? So of course, the stress level is very high, their hormones are all over the place. So you make the right choice and right protocol for them. In these cases, I usually tend to go with a higher dose because I'm not worried about the ovarian hyperstimulation. But starting the high dose right from the beginning is because you are trying to wake those sleeping eggs right from the beginning. If you increase the dose later on, it's of no use. You have to push them right from day 1 or 2 of the cycle. Yes, later on you can increase the dose as the follicles are growing further. But best thing is, in these cases, you can put more salt. Okay, you can start with a step, up protocol, but not in the high responders. So I think we have already talked about this. Now, the difference between the HMG, as I said, that they are produced from the postmenopausal women urine, and the gonal-F or the recombinant FSH is better these days because of high consistency, high quality. But with the HMG, it's usually low consistency, and also safety concerns of it's derivative from the human urine, and also it's low purity. And I'll show you one study later on where there is a batch-to-batch variation using these HMG rather than the recombinant FSH, which has got the same dose throughout. Okay, so select the gonadotrophins rightly from the beginning to get a better live birth, to get a low cost per birth, and also less time to birth, because it's also very important for infertility patients. They come to us and they want to get pregnant as soon as possible. But sometimes you say, listen, darling, we have to freeze your embryos, we have to do genetic screening, then we have to do other things on the endometrium, and it may take 2 to 3 months. They say, really, doctor? No, I want to get pregnant, this date, so that my delivery date is in certain time. And you cannot sort of guarantee them that they will have a pregnancy next month and they will have a delivery in 9 months so that they can go and enjoy their holiday or whatever sort of plans they have. So it's really, again, very important that you counsel the patients right from the beginning with this, okay? Sorry. Okay, so this study was by Ravelli et al. In 2006, and they looked at it was a single center study. They looked at the cost minimalizations, that it was a randomized control trial. And if you see, the purple is the use of recombinant FSH, and the orange is the human menopausal gonadotrophins. So the cost of using recombinant FSH was less, and equally the delivery was better. So the live birth rate is more. Over here also using in ovulation induction with IUI. So again, if you see the total dose used in the recombinant FSH, which is the purple one, it's less doses used, but the clinical pregnancy rate is much higher with the gonal-F, which is the purple. And also the dominant follicles would form better with gonal-F. So just sort of comparison, if you see, the purple is the recombinant FSH, the orange is the human menopausal gonadotrophins urinary, and the other color is HMG. So again, showing in those patients, the group 1 PCOS patients, you have a better outcome by using recombinant FSH in terms of clinical pregnancy and less cost. This is what I was talking to you about, that if you use the HMG, there is a dose-to-dose variation in the medication that you give. But if you see the pre-filled one, the pink one at the bottom, it's consistently the same. And we have seen that if we start stimulation for one patient in certain cases, one patient may respond differently and the other patient may respond differently, or even in the same cycle, sometimes it's different because there's dose variations. So keeping in mind, that's with the recombinant FSH and the pre-filled syringe is a better outcome. Coming to the risk of OHSS with these, this was a Cochrane database review published, which shows by using HMG with 75 international units, the risk of OHSS is much higher compared to use of recombinant, 13% versus 2.7%. This was a very large study published in by Bowler et al. In 2021. It's a real-world study where they looked at over 28,000, nearly 27,000 patients in 71 centers in Germany. And they compared the effectiveness of recombinant FSH with HMG in IVF treatment. And they showed that it's a forest graph. So if you see to your right, that shows the reference one is the gonal F, the recombinant FSH. It shows much higher live birth compared to the HMG. And similarly, if you see this, the bottom graph, sorry, the marker is not working, but if you see the bottom one, that shows the time to live birth. So it's much shorter compared to the HMG. These are the three forest graphs, which is comparing the live birth, the ongoing pregnancy rate, and the clinical pregnancy rate. And to the right of your right, that side, it shows a much higher rate with the recombinant FSH, okay? Whether it's a clinical pregnancy, ongoing pregnancy, and live birth. Also, I just want to touch this point is very, very important when you're counseling the patient about the pregnancy rate. Please, please, please don't tell them the pregnancy rate on a biochemical pregnancy. A patient comes to me to take a baby home, isn't it? You're not coming to me to just say, congratulations, you are pregnant. So it could be 80% in your center. In my center, it's 83, 84% biochemical pregnancy. I never tell them about biochemical pregnancy because there's always a drop of 20, 25, 24% from the biochemical to the clinical pregnancy. So the clinical pregnancy is sort of, it could be for you, it could be 60%, it could be 55%. But then there's a further miscarriage risk of 11 to 13%. So what is the live birth? You have to be honest to the patient. So I tell them, this is our live birth rate. So they say to me, doctor, your rate is so low. The other doctor was saying is 80%. I said, I wish it was that. It's not because they're talking about the biochemical picture. So that's, again, very important for the doctor to be honest to your patients. They will accept it because that's international. If you see the live birth in UK, under 35 is 19-20%. Over 35 is 19-20%. Under 35 is 25-27%. The same as in Europe. America is slightly higher because they transfer more than one embryo. In UK, we go for single embryo transfer, and still the rate is very good. In our center, we are very much on single embryo transfer. My pregnancy rate, our center pregnancy rate is in the region of 45 to 48% in patients above 35. And it's 55 to 56% in patients under 35. So be honest to your patients. Sorry, I'm diverging, but it's really important that I want to get this point across. So in summary, with the recombinant FSH, we use lower gonadotropins. There are few number of cycles because the cumulative pregnancy rate is better in them. There's shorter time to live birth. And of course, there's lower risk of cycle cancellations. And there's no difference in the rate of pregnancy loss or miscarriages. So this is again the cost effective, because I'm banging on the cost, because IVF and any sort of medical centers or business, they look at the cost. So in here, if you look at these three different cycles, they compared the live birth with gonal F and the cost with the HMG. And if you see, the purple and the pink are the gonal F, and the lemon color and the purple, the light purple is the HMG. And you see consistently in first cycle, second cycle, third cycle, there is it's cost effective to use recombinant FSH, okay? And this was also from Germany. The study was done in Germany and pretty recently in 2022. Again, this is looking at the birth cost and the total number of live births. So it's higher treatments, like if you see, there is the 3,756 euro in the recombinant FSH, but over there is 3,703. This is because they had more live births in there. That's why the cost was slightly more. But if you see comparing, the cost is head to head. So it's much better with the recombinant and higher pregnancy rate with that. This was another larger study in America done from 2015 to 2018. 31 US centers were involved, and they looked at 620 women who had an AMH of over 5 nanograms, and those women were aged between 21 to 35 with a better BMI, that is between 18 to 30. And it was a randomized assessor-blinded trial which compared the recombinant FSH with the HMG in PCOS patients only. And those patients who were at the high risk of PCOS, these patients, the embryos were frozen and then they were transferred 6 months later. And they looked at the cumulative outcome per cycle and per period. So if you see here, there were lower dose was used. The total dose of gonadotropins in the HMG was 2,114, but the recombinant was 1,489. So again, it's reduced the cost, and also the duration of treatment was on the average with HMG was 10.9 days, but the recombinant FSH was 9.3 days. The same in here, if, there were more number of eggs collected. So the HMG 15 eggs on the average, with the recombinant FSH 22 eggs, and the number of blastocysts were more with the recombinant FSH, that was 8.5. And also this is another randomized control trial, different studies that showed that the number of eggs collected with the use of recombinant FSH is much higher compared to the HMG. Coming to, I'm going to leave HMG now, and I'm just comparing likes for likes, okay? So if there was this study by Viso et al. In 2018, where they compared a similar type of product, like Bemfola or Overleap or Primaport, is basically the same FSH that they have, and they compared it with the recombinant FSH. And again, if you see to that side is the reference, the biosimilar one on that side, and on this side is the reference one. And if you see this forest graph, again, it shows much better outcome with the recombinant FSH than comparing it with a similar product used in different countries. So these biosimilar ones are used in Italy, Germany, and Spain. So they did this study where they compare these products. But again, the market leader was the recombinant FSH. And the same study, they looked at the cost effectiveness, and it was much better with the recombinant FSH. What about, we talked about FSH. What about the LH activity delivered by recombinant FSH versus the HMG? Again, these different studies have shown, Muller was the one who did the Germany study they did previously had done in 2011, where they looked at 4,719 patients, and they showed that there was a high clinical pregnancy rate when you use the 2:1 ratio of FSH versus LH compared to the HMG, or combination of HMG with some other products. Again, I know some physicians and doctors, they are using combinations of FSH and HMG and this and that, but it does not make any difference. I think as a physicians, we are treating ourselves rather than the patients. So the studies are very clear and evidence is very clear that either you use the pure recombinant FSH and LH, or you can use a combination of the HMG. The other studies also 2014, Fabricus and Dahan in 2014, they also showed that you get increased number of oocytes when you use a combination of 2:1 ratio. So the megaset study, which is the American one, it did show that recombinant FSH got more eggs collected, more mature eggs, because that is again for IVF people that we want mature eggs, we don't want immature eggs. So by using the gonadotropins, we get better mature eggs, we get more blastocysts, and the total dose is used, of course, the cost effectiveness. And also, you can adjust the dose, as I alluded to earlier on, that you can adjust the dose very easily with the recombinant FSH pen. So this is all about physicians. What about the patients? And we constantly ask about the patient satisfactions, about the patient's views. And there was a study which showed that comparing the use of these pen, gonal F, compared with the mixing of these different vials. And 90% of the patients were in favor of using these pen because it's easy to learn. And also, it's not only patients, even the nurses who are teaching the patients, it's better for them. And, you know, all patients are very intelligent, but the level of, you know, understanding and intelligence varies. So it's, you know, we go to the same level to make the patient understand. And it's better to have with this pen because you can adjust it rather than mixing, because sometimes we get patients who have used, you know, less or more, and then they say that there's no response, but it's just, you know, the understanding and the ease of using it. So with this pen, you can easily go by increments of even 37.5 this, and then slowly and gradually increase it. The risk of OHSS, this was, again, is a safety profile that it was a real world study for over 25 years in RCT, looking at the pharmacovigilance in different countries, so British Isles and Netherlands and UK, and all different systematic reviews. And if they showed that, I'm not saying that OHS doesn't occur with using recombinant FSH, but if it occurs in a very mild and moderate state, not in severe state. And this study has proved that most of the OHSSs which occurred were in a mild and moderate form, and, you know, 3% or 1.2% moderate, and the severe one is less than 1%. So the different color bars represents the different countries where the treatments were done. So it brings us to our conclusion that it has to be a treatment that you give, it has to be very tailor-made, and unfortunately one size doesn't fit all. So if you properly plan the treatment, it should be like a one and done approach. Individualization, I'm sure now I have hammered so much about individualization that you must have got the concept that's very important to deliver a quality of care to the patients in terms of safety and effectiveness. And recombinant FSH, it increases the live birth rate, which is what, you know, the clinicians and the patient wants, and at the cost of causing less risk to the patients, less cost to the organization and to the corporate, and also there's not much difference in the other products. Thank you very much.
It was wonderful lecture hearing you. Any questions from the audience? If there is questions to Dr. Yasmin, can we ask now?
Please.
Thank you for the lecture. I want to ask about the role of Qaboos to reduce the incidence of OHSS.
Yes, thank you very much. That's I think I'm in the middle. I wanted to say, and then I got diverted on the other side. But thank you very much. That's very, very important. In my practice, I use Qaboos a lot in these patients. I give it before the trigger, and cabergoline is what it does it that in you all are obstetrician gynecologists. You know in preeclampsia the capillaries gets leaky. Okay, and it leads to ascites and accumulation of fluid in the third space. The same thing happens in patients who are at increased risk of OHSS. Their capillaries, the vessels are leaky, and they have activation of vasoactive factors, VGF factors, right, receptors. By giving cabergoline, it puts a lid on the VGF receptors. So when you give them trigger, you have to do that before the trigger. So when you give them trigger, those VGF receptors does not get activated and the risk of OHSS is reduced, right? So we give it before the trigger and I continue it for 7 days after egg collection, right? And also, the moment I get their eggs collected, I put them on the GnRH and the antagonist, cetrorelix, because when you take the eggs out, all the medications have gone off of the system. The patient's own pituitary will start working. So you put a lid on that so that their own inherent FSH doesn't flare up and the ovaries does not flare up again. So by giving the cabergoline and the antagonist for sort of 7 to 10 days till they have their next period, you keep the lid on the ovary. And touch wood, in my career, I have come across very mild OHSS, which I usually manage on outpatient basis. So it just by having these, so plan protocol, step up protocol, using cabergoline, using antagonist, embryo freezing, or posting and all that we do. So cabergoline does have a role and studies have shown that it is effective.
Thank you. Other question which is annoying us during the management is the love.
What, sorry?
Love, this luteinizing and ruptured follicle.
Mm-hmm.
So how to can avoid this during, or how to manage if we are facing it?
Ruptured, you're talking about ovulation induction? Okay. Again, it's, to be honest, I hardly use antagonist, right? So when I start ovulation induction, if I'm with PCOS patients, I use a lot of letrozole. There were studies which were done comparing head-to-head Clomid with letrozole. Letrozole has shown a better results with ovulation induction, right, in patients who are PCOS. But you have to inform the patients that in the first trimester, it's still not been proven whether it caused any abnormalities in the first trimester or not, but you have to inform the patients that there could be a small risk of that. Again, it's not been proven, the studies are still ongoing on that. So when we give the letrozole or Clomid, and I bring them back on day 9, I don't bring them back later. So maximum day 9 and 10. And when she has if for example, on day 9, 10, she has a follicle of 14 millimeter, I bring them back alternate day. And when the follicle is 16, 17 millimeters, I give them trigger. If by chance the patient is not coming or cannot come, then I might sort of add the antagonist to it. So prevent this rupturing. That's a different story. If the patient comes to you and she has already got a 20 millimeter follicle, then you can't do anything about it. I had actually 2 weeks back, I had a patient, she wanted ovulation induction. We started and she did not tell me that, her husband is not here. She wanted to do the SI, sexual intercourse, not the IUI. So I scanned her and she had a 22 millimeter 2 follicles, okay? And I said, okay, so we're going to give you a trigger today and 35, 36 later, you're going to meet with your husband. And she said, my husband is coming in 5 days' time. I said, you didn't tell us this. Doctor, please do something. I said, I'm not a magician here, but let me start you on it. So I started her on double dose of antagonist. So I gave her, instead of 0.25 cetrotide, I gave her 0.5 milligram of cetrotide. And this is, I scanned her on Ooh, I scanned her on Wednesday and the husband was coming on Monday, right? So I said, let's keep our fingers crossed and let's see if these follicles, but if they're ruptures, I can't help. So she came on Friday, thanks God, alhamdulillah, the follicles were still there and we gave her a trigger and then I'm waiting for the pregnancy test now. So you have to individualize it. You have to plan it that way. So ovulation induction, bring them back a bit early rather than bringing them at day 12, day 14 or whatever. Does that answer your question? But if you have got a ruptured follicle, corpus luteum, gone. Anyone else?
Anybody else?
This is your time.
Any question?
Hello.
Can
you tell me the role of oxytocin for trigger?
Oh, wait, sorry?
Role of oxytocin for trigger.
Do you want an honest answer?
Yes.
I've never used oxytocin. Okay, I've been in this field for now nearly 30 years. I've trained in UK. I've been in UAE now for the last 6 years. We never used it in UK. We never used it in here. So I'm sorry, I cannot comment on that. And I have not come across anyone using oxytocin or any recent studies.
Thank you.
Thank you.
What is the maximum age you accept a women for IVF and ovulation induction protocol?
You have opened a Pandora box now. When I came from UK, in UK, the cycles were on the government things. They were eligibility was only 42 years. That's the end, and other criteria. When I came to this country, there was no age limit, right? Patients were even coming at the age of 50, 51, 52 and all that. But of course, you have to be very sensitive. What about developing a follicle on her ovary? It's a long way that you have to go. They have, again, I said, they have come to you to take a baby home. By developing a follicle, I think your physicians are treating themselves, it's not the patients. And the patients, they come and they say, yes, doctor, the other center they did, and they saw egg. I developed 1 egg and 2 eggs. And I said, no, that it's not egg. Nobody can see egg. It's like you go to the supermarket, you see whether in grapes, so you see whether there's a seed or not. You can't till you eat it. So the same is when you follicle, you take the fluid out, you examine it under the microscope. So you cannot tell whether there's egg or not. So you explain to the patients, one, it's not an egg. Secondly, even if you went and we got an egg from you, what are the chances of that egg getting fertilized? Even if it gets fertilized, right? What are the chances of embryo aneuploidy, right? Even if it gets normal, what is the state of endometrium, the pregnancy rate, okay? So the studies have shown that at the age of 34, 35, you need 6, 7 embryos to have 1 normal embryo. At the age of 38, 39, you need 10 embryos to have 1 normal embryo. 40, 41, you need 15 embryos to have a normal embryo. 42, you need 20 embryos to have a normal embryo. So I explain all this to them, and then you go up to sort of, in this country, I had a twin from a 46-year-old. But it's again, she had endometriosis and all sorts. But the success rate of live birth after the age of 44 is less than 1%. So you have to be honest to the patient. They say to you, My cousin or my friend had a baby when she was 48. Is that statistically significant? No. You have to take into consideration the population. You have to take into consideration that it's not one person. If one person, your friend had that, it doesn't mean that you will have that. So counseling is very important. Yes, we're getting patients 46, 47, but thanks God now, I'm very much involved with the DOH, with the guidelines, and now the recent guidelines on the fertility, which came out in July 2022, which they say that anyone above the age of 47, we should not be stimulating them. Unless and until they have an antral follicle count of more than 5, or the certain AMH. Previous guidelines was talking about the AMH. But then now is the AMH and the antral follicle count, which is again antral follicle count is a very subjective, because I have seen physicians just turn the thing and it's, oh, there is 2, 3 antral follicle there, and so that they can qualify for the insurance, because in Abu Dhabi, there is insurance, they pay for that. And if the antral follicle count is less, they will not pay for it. So to answer your question, I'm sorry, it's a long discussion, but as per the thing is 47.
Thank you very much. Keep the frozen embryos.
Frozen embryos, we can keep up to 50 years. Now the new guidance which came out in UK, the gametes, eggs, ovaries, or embryos, you can keep up to 50 years. In this country, by the federal law, we can keep it for 5 years, and we can extend it every year. So it does not affect the efficacy of the embryos. The reason why they say 50 years is because the cancer patients, for example, I have retrieved sperm. I'm an andrologist as well, so I do surgical sperm retrieval. So in UK, I operated on an 11-year-old boy who was going for chemotherapy. So because he could not produce an ejaculated sample, so we have to take testicular tissue. And that child, he's 11 years old, and by the time he goes to he might be 35, 40. So we keep their sperm, we keep their the female eggs or the ovarian tissue, and the embryos. It can be kept up to 50 years. Recently, 2 weeks back, there was a live birth in UK from embryos which were frozen for 32 years.
You charge more?
I don't charge. No, the charging is per year. So it's either 100 dirhams or 150 dirhams, something like that. It's not a mega amount, yeah. But the thing is that when the patient comes in, I always counsel them to go with a single embryo transfer, right? Everybody say, I want 2, 2 for the price of 1. But if you tell them that it's less risk, with a single embryo transfer, and equally we can keep these embryos for you, and then you can come and use it at a later date. So it's better with less risk.
So you can have multiple children with the...
Yes, yeah. I have patients here, a patient who had 13 failed IVF cycles, and she had 8 miscarriages. She came to me and wanted me to give her a report so that she can go abroad and have treatment. So I said, your government brought me here to do the treatment. What is this difference? No, because everybody, they want to go abroad and they think, grass is green on the other side. But I said to her, I said, listen, I have not done your treatment, so I cannot sort of give any report, and I would not send you. Yes, if there was something which was not available in this country, I would have given you a thing to report to go. She was very angry. She went and reported me to Seha. I was working in Seha before, and they asked me, and I said, listen, I cannot justify myself to give a report, but I have got expertise, I have got all facility here. So I said to the patient, give me one chance, just one chance. And she was again PCOS, she had multiple OHSSs before, and then even the implantation, she would get miscarriages. So with the first, when we did, I got 35 eggs from her, and from 35 eggs, we got 28 embryos frozen. The first cycle, I agreed to transfer 2 embryos. I normally don't, but I did. She was 35 years of age, and she had twin pregnancy from that first, right? She had a live birth. And then you could see the smile started coming, because every time she would come, she would be frowning and, like as if she was going to kill me and eat me up alive. But then you could see the smile started coming up. She was very happy after her live birth. Then a year later, she came and she wanted to have another pregnancy. And she said, and I said, please go with a single embryo transfer. No, again, she was stopping and, all sort of creating a drama. And I asked her to, okay, sign a disclaimer, because if any complications happens, I'm as a clinician, my job is not to make you, let you make a dangerous decision. So I'm advising you not to go with this 2 embryos, go with a single. So she said, I'm ready to sign anything and all that. So she signed a disclaimer, and we had to transfer 2 embryos. I had to take a second opinion and third opinion, because as a clinician, you have to cover yourself from all angles. 2 embryos, when she came for the first scan, it had split. But still, she was very happy. So in 2 goes, she had 5 pregnancies. And we still have got, now I think, over 10 embryos with her, for her.
When do you do PGT or screening before embryo transfer? In which cases do you do? In every case?
No. There is set guidance on the PGS. We don't offer it to everyone. If somebody has got recurrent implantation failure, more than, i.e. 2 or 3, people who have recurrent miscarriages, male factor infertility, if the sperm count is very low, also if they have a family history of genetic abnormalities. We do a lot of PGTs, because in UAE population, because of the intermarriages and all that, there's increased risk of different genetic abnormalities. So we do it in those cases, not for everybody. And any patient who is above the age of 35, because of the risk of unemployment. So UAE government, mashallah, is very generous, and they're looking after the people. In UK, PGS is not as commonly used as in this country. So you guys are very blessed, mashallah.
I think the cutoff age is 38 years or so. 35 plus, they are not doing.
Yeah, over here the guidelines we have is about 35 automatically, because now before starting any IVF cycle, we have to apply for approval to the insurance. And if these criteria doesn't meet, you don't put any of these, or the patient does not have that, then they would not approve the PGS for them. And did you ask when do we do it? Yeah. So the PGS, the genetic screening is we do day 5 embryo biopsy. We don't do day 3 embryo biopsy because on day 3, and this has been proved by studies, on day 3, the embryo is 8 to 10 cell stage. The embryo has still got 2 more days to do. So the embryo cell, it can auto-correct itself. So the cell which you took out on day 3, that cell which could be abnormal, but you don't know the other cells which already is there are normal, and you base your conclusion on day 3, this cell, that this embryo is abnormal, and you don't transfer. So it's better to go at a blastocyst stage to have the trophectoderm rather than the cell. So day 5, day 6 is a far better results compared to day 3. So we don't do day 3 biopsy anymore.
Thank you so much.
There are some questions from online participants as well.
Only one question now. What to do for these patients, because we are at receiving end when they come with IVF failure, and there is nothing on hysteroscopy also, no local factors. So how to address that?
Again, sort of every patient you individualize, you see sort of their outcome. If they have good embryos, right, development, the biopsy, I would go day 5. I would never, because if I'm doing day 5 biopsy, I'm giving them false hope. I would rather have a proper assessment. So one is the embryo. Once you have a good quality embryos, then you concentrate on the endometrium. Again, I say to my patients, I said, I'm a farmer. Okay, one, the farmer concentrate on getting a good quality egg. Once you get a good seed, once you get a golden seed, then you go and concentrate on the field. So you plow the field, you water the field, and then you get the right temperature, and then you put the seed in there, and then you support it with fertilizer and all that. The same thing happens. So once you got the embryos frozen, then you start concentrating on the endometrium. So hysteroscopy, yes, hysteroscopy is one of, but again, it's not previously the studies came out that hysteroscopy should be done a month before, but they'll still be waiting randomized controlled trials. It's not been proven. So I use colony growth stimulating factors. I basically the luteal support and different things, but nothing is 100% guaranteed. So here comes again counseling. You inform the patient, you counsel the patient, and they will understand.
Thank you.
Hi, Dr. Yasmin.
Hi,
We have 45 participants online, and they have appreciated your presentation.
thank you very much. I'm very humbled.
And you look very beautiful today.
Thank you very Thank you very much.
What is the role of prednisolone nowadays, especially when it is used in many centers?
Okay, thank you very much. Yeah, that's a very interesting question. My MD and my research was done in UK, and I was very lucky enough to work with Siobhan Quemby. She's a world-renowned on recurrent miscarriages. And she sort of showed that you use the natural killer cells in the uterine natural killer cells. The role of prednisolone is only in there, right? There are two types of natural killer cells. One is in the serum and the other one is in the uterine. It's not the serum one, it's the uterine. So if you have raised natural killer cells, it's shown, then you can use the prednisolone. And prednisolone, there's no use of giving 5 milligram or 10 milligram. You go with a 20 milligram dose, start at the time of embryo transfer. And you counsel the patient again that you should take the prednisolone in the daytime because it can affect the sleep, it can affect the appetite, you might be gaining weight. Sometimes there's a very small risk that the baby can develop cleft palate and cleft lip. So as long as you counsel the patient that way. Once you transfer the embryos, you start prednisolone and you carry it on till the pregnancy test. When the pregnancy test is positive, you continue it till 12 weeks, right? But from 10 weeks, you start tapering it down with an increment of 5 milligram every second or third day and stop it completely on 12 weeks. So to answer the question, I'm a great fan of using prednisolone in these cases and recurrent miscarriages patients.
There's another question. What is the role of, in a normal induction cycle, what is the role of recommendation for recombinant HMG?
Role of, I think I showed you different studies.
What is that recommendation?
Yeah. To be honest, I use recombinant a lot, right? Even in the hypogonadotrophic hypogonadism men, I use recombinant. But they can use it, nobody can stop. But whatever the evidence shows, I think you can go by that.
There is another doubt regarding gonadotropins. When used for normal responding cases like PCO and the role of LH as mentioned, FSH LH 2:1, as already have their endogenous high LH levels, should it be purified?
I never said that use FSH and LH. In PCOS patient, you use the FSH, right? It's different if the patient is about the age of 40, 41, 42, then you can use 2:1 ratio, right? But at that time, I have yet to come a PCOS patient at the age of 43, 44.
Thank you very much.
Thank you.